Right, I'd like to welcome everybody towards this next paper-free session. The session is on fragility, fractures, and miscellany, and it's my pleasure to co-chair this session with my colleague Mike Grevitt, a consultant spinal surgeon, and myself, Apinda Sahota, consultant physician. What we plan to do at this session is to run through all three of the free papers, and then we'll kindly ask our speakers to join us at the end, and hopefully we can have a further informal review of the papers. And can I kindly ask the individuals if you could kindly use the chat box for the questions and any questions that you may have. So we'll run through each of the presentations. So presentation 1, pedicle screw insertion and educational assessment of accelerated learning. Presentation 2, vertebral augmentation for painful type 4 osteoporotic compression fractures, a comparative study. And presentation 3, implementation and adoption of streamlined acute vertebral fracture compression VCF pathways. So thank you, Alan. If you could kindly play the
thank you for your
sessions.
kind invitation. This is Mr. Fragakis Evangelos, complex spinal fellow at St. George's University Hospital in London, and I would like to talk to you today about our experience from the pedicle screw insertion course of accelerated learning. Before going into the results, let's see actually what making us an expert. As Professor Anders Ericsson was suggesting in 1993, that it takes approximately 10,000 hours in a certain task to become an expert. But is this still applies in today situation with the workload we have? According to Josh Kaufman, anyone can learn nearly anything in just 20 hours by taking into consideration his 5 steps. Certainly by defining the specific goals, deconstructing the skills into subcategories, focusing on the most frequent use sub-skills, eliminating the barriers of practice, and of course, be pre-committed to the first 20 hours. We can certainly say that pedicle screws are a game changer in spinal surgery, and over the years they have been developed safe techniques and instrumentation to allow a successful placement of the screws inside the vertebral bodies without affecting the surrounding nerve structures. But is it always the case? Certainly, we can have intra-postoperative significant complications with dramatic outcomes. Therefore, how many screws it takes really to improve our accuracy? According to this study, with approximately 150 screws, we can have a significant accuracy, and with a number slightly short of 300, we can be almost perfect. Nevertheless, above 300 screws, we can run into complications occasionally, perhaps due to overconfidence. This other study on thoracic pedicle screws in adolescent idiopathic scoliosis patients is telling us that it takes approximately 100 cases to optimize the screw placement time. But therefore, how a perfect course should look like? Certainly by teaching the pedicle screw techniques, saturating the audience with experience, satisfying the learning curve, having a high trainer to learner ratio, and guaranteeing an immersive and intense experience. But how this should look like? Our course in St. George's usually is composed by 6 senior fellows, 3 spinal consultants, 2 cadavers per fellow, runs into 3 days, and the plan is to place safely 156 pedicle screws per fellow. Does it work? As we can see from the graphic, as the course goes by, the time to instrument the thoracic spine reduces, and similar is the situation with the lumbar spine. In addition, Slower means always safer. This graphic is telling us that actually this is not always the case. And certainly, as this other graphic suggests, with the experience, the total time reduces. Certainly, this is in line also with confidence. More confidence we are, the time for screw placement is reduced. Very interestingly, there is also a correlation between time and anxiety. Reduces the anxiety, less is also the time. Very interestingly, there is also a correlation between anxiety and confidence, which are coming together as this graphic is suggesting. Now let's talk about the errors. Observing the thoracic progression, we can see that there is a gradual reduction on the errors over time. Nevertheless, there are some turbulences on the lumbar part of the spine. Over the years, we came to the conclusion, as we can see in the highlighted part, that due to an accumulated fatigue over the days and perhaps due to overconfidence, there is an increment of mistakes towards the end of the course. And this is in line with the studies that we have shown above. This is a course that runs for 9 years and continues, and we would like to improve it by making the process more interactive, more enriched with multimedia material, and also giving emphasis not only to speed, but also to safety, possibly with rewards. Thank you very much.
Welcome everyone. My name is Ricardo and I'm going to present a study we did at Imperial College NHS Trust entitled Vertebral Augmentation for Painful Type 4 Osteoporotic Compression Fractures. This paper was written by Mr. Abdallah, myself and Mr. Umbridge. The management of osteoporotic vertebral compression fractures is still controversial amongst us. Most of these fractures do not necessarily require surgical decompression and can be managed conservatively. Nevertheless, conservative management in this group of patients, often elderly with other comorbidities, can result in several complications, such as bed rest, respiratory compromise, spinal deformity, and the risks associated with opioid use. The German Society for Orthopedics and Trauma treats osteoporotic fractures as a separate entity and classifies them into 5 types. This has helped establish the guidelines for the treatment of each type of fracture. Due to their instability, surgical fixation is indicated for OF4, with or without added cement augmentation. Given that no previous research has studied the response of this subtype of fracture to vertebral body augmentation, the purpose of this study was then to evaluate the response of this fracture type to standalone vertebral body augmentation. The study was done across 2 hospitals and evaluated the effectiveness of percutaneous vertebroplasty or kyphoplasty in controlling the pain in patients with OF4 fractures. We reviewed all osteoporotic vertebral compression fractures treated between 2016 and 2020 and included the OF4 subtype in this study. The group treated with vertebral body augmentation was then compared to a group of patients undergoing conservative treatment. We've included every patient above 50 without any neurological deficits, with radiologically confirmed osteoporosis, and with complete medical records. And we excluded patients with any coincident fractures, follow-up carried out at different hospitals, patients who had received any other concomitant spinal interventions apart from the biopsy, or patients with other spinal pathology proven from the biopsy, such as metastases. Visual analog scale was used to assess pain score at time of diagnosis and in the follow-up period. The outcome was considered successful if there was a reduction of at least 4 points in the scale. All of the augmented cases had a period of failed initial conservative treatment and severe pain before the vertebral body augmentation. The duration of this treatment varied between the cases. Fisher's exact test was used in order to compare both groups. Subgroup analysis of the 3 types of F4 could not be done because of the small number of cases, and we have accepted a p of less than 0.05. A total of 84 patients were identified, out of which 25 had OF4 fracture types. 10 patients received vertebral body augmentation, 70% vertebroplasty and 30% kyphoplasty. 70% of them had single add-on fracture. The other 15 patients were treated conservatively, 86.7% for single add-on fracture. The average age of OF4 group patients was 78.4 years in the conservative group and 74.7 years in the surgical group. The sex distribution was nearly similar between both groups. Mean follow-up period was 3.7 months in the conservative group and 4.8 months in the surgical group. Fractures occur most frequently in the lower thoracic and upper lumbar levels, and the level of fracture had no statistical significance between the two groups. OF4 showed poor pain alleviation with conservative treatment, but statistically significant improvement with vertebral body augmentation with a P of less than 0.01. OF4, although classified as an unstable fracture, can still be treated with vertebral body augmentation since we found it achieves satisfactory pain control. None of the patients in our study had surgical fixation. Early treatment of these fractures is recommended as shown in the VAPOR study, but our results still showed good outcome even with delayed vertebral body augmentation. Despite this, it was a limited study since it was retrospective with a small number of cases, and there was a shorter follow-up period in the conservative treatment group, which, even though it's not significant, can create a bias in our results. So going forward, we need to do a prospective study with more detailed outcome scores and with larger number of patients. So in conclusion, vertebral body augmentation can be an additional means of pain management in pains with OF4 type fractures. Thank you.
Hi, my name is Vicky. I'm a junior doctor at Buckinghamshire Healthcare Trust, and I'm going to be talking to you about the implementation and adoption of our new streamlined vertebral compression fracture pathway. Fragility-related vertebral fractures are very common and a huge public health issue. Around 25% of women over 50 will have a VCF at some point in their lifetime, and these all come with pain and with worry and functional impairment for patients. And this places a burden on the NHS at a cost of £134 million a year. And with an ageing population, the numbers of vertebral compression fractures will continue to rise each year, with the costs projected to increase by 24% to £166 million a year by 2025. And once a patient has a fracture, they're at a 5 times increased risk of suffering another fracture, with around 20% of women having recurrence within 1 year. Each fracture accounts for an additional 14 GP visits within the year following, likely due to poorly controlled back pain, worry or recurrence. And even though we have the evidence to suggest that starting bone protection treatment can reduce the risk of fractures by up to 80%, only a fraction of the patients receive this important preventative measure. So, we looked into how our trust has been managing this problem. We identified patients through radiology reports, looking for keywords to capture all hospital inpatients, A&E attendances, and patients referred for imaging by primary care within a 6-month period, and we identified 67 VCFs. Of these, the vast majority were at T12 level, and most were uni-level fractures. Predictably, the fractures were most commonly seen in older patients, with 3/4 happening in women, and the vast majority of these were picked up on simple imaging. This slide summarises what we found. 2/3 of patients were offered some kind of pain relief, just over half were recorded as being offered bone protection, and only 13% were offered MDT input from physiotherapy. Only a tiny number of these fractures required vertebroplasty and none at all required surgical intervention. So, in order to streamline patient care and ensure all patients are being offered all of the key points of management, with pain relief, physio advice and bone protection, we developed a pathway that is now in place for our trust. All clinically suspected VCFs can be included, with key exclusion criteria being young patients or traumatic mechanisms of injury that might suggest the fracture is not purely osteoporotic, or any related neurological impairment. Once a VCF is clinically suspected by A&E on the wards or by local GPs, X-ray is requested to confirm the diagnosis, and we highlight here the need to explain and reassure patients. We recommend that all patients are offered 3 key points of management: basic pain control as needed, physio input, which can start with something as simple as exercises explained in a specialist leaflet, and bone protection to help reduce the risk of recurrence. Crucially, any patients who do need to be admitted will be admitted under orthogeriatrics. Any suspected VCFs not confirmed in X-ray can proceed to CT or MRI if needed, and then onward referral to specialist services if required. And similarly, if symptoms aren't resolving after a prolonged period of conservative supportive management, onward referral to specialist services is still an option. The benefits that we see to this pathway are both to the health service in utilising the full MDT approach, especially the orthogeriatric component, avoiding unnecessary hospital admissions, and reducing the cost of patients re-presenting with poorly managed pain, worry or recurrence. And crucially to patients themselves, who can be reassured and empowered to manage their conditions safely and effectively, often in their own homes, as well as freeing up specialist clinics to become more accessible for those patients who do require further specialist input. This model is a simple way to streamline services and improve outcomes, and we hope to see a similar pathway adopted around the country.
I'd like to thank our 3 speakers for a really excellent, succinct and clear presentation. I'd like to hand over to my colleague Mike to kindly facilitate any further questions. Thank you, Mike. I think you're still on mute, Mike.
Thank you. Yeah, we'll just give a few minutes for our speakers to be admitted to the room. Is Darren Liu? Yes, Darren, you're here as well. So can we just start, Darren, because again, we have a question for Almas Khan here. Adjacent level fractures with this augmentation in OF4 fractures. Is it a bigger problem than we'd see otherwise?
Can everyone hear?
Yeah, Darren, you're very quiet. If you could come closer to the microphone, that'd be great. Darren, did you hear that question?
So if he's still not sure thinking, maybe can I also pose a question to Vicky, if you're here as well, Vicky. So Vicky, we just had a meeting this lunchtime with senior management in our hospital. We talked about right place, right time for the index event. So really the question to you is on your pathway, and the question we were discussing at Trust Board this morning, where should acute vertebral fractures be admitted to? If clearly the index event is spinal injury, spinal fracture, should all these patients go to a spinal ward?
No, so the main focus of what we are trying to achieve is to get these patients admitted primarily under orthogeriatrics if possible. Orthogeriatrics in our hospital are very on board with that plan. They're much better equipped to deal with a lot of the social issues that come with this demographic of patients. So the first port of call would be the orthogeriatric ward. And if orthogeries felt that there was further specialist input needed, then they would discuss with spinal further to that.
Thank you. Sorry, Mike, back to you.
Yeah. Ricardo, that question from Almas was for you, if you could answer that. I didn't realise that you were online. So Ricardo, could you answer the first one about adjacent level fractures following OF4 fractures? No. Ricardo, are you there? If you could type something if you're having difficulty with your... whilst we're waiting, perhaps... a question to Vicky whilst we're waiting, and perhaps sort out childcare issues. Vicky, a question. Why are you waiting so long, 6 weeks in Stoke before some vertebral augmentation?
Sorry, I missed that question. Could you repeat it?
Yeah, the question is, why are you waiting so long, i.e. over 6 weeks before considering vertebral augmentation?
Because the vast majority of the cases that we saw in our audit didn't require any further specialist treatment in the end anyway. And it usually took about 6 weeks for people to reach the specialist services and referral. So if we can try and get people started immediately in A&E or in GP when this is first picked up on the right physio and the right analgesia and the right bone protection, then it can avoid a lot of the onward referrals that may not be needed. And it is, we do allow for a case-by-case basis. If people think that their patient needs to be referred onwards faster, that is part of the pathway as well. But it's trying to avoid unnecessary referrals because the vast majority aren't needing referral in the end.
Thanks, Vicky. Whilst we've got you on sound, one question from Aprajay Golash. What do you think about bracing for pain relief in terms of the hierarchy of interventions?
Again, we weren't seeing a lot of need for it in our particular sample. The sample we looked at obviously is limited by the fact that it has been within the sort of time period that COVID has been. So what we'd be looking to do is we're going to look further back to see what we've been doing in previous years before we compare, hopefully once COVID starts allowing for more of these interventions to be re-implemented. But I'm not sure we were seeing a lot of need for bracing in the sample that we had in particular.
Ricardo, is that you? Can you nod your head?
Yes.
Okay, fantastic. Great to have you on board. So, Ricardo, there's a question from Amos there in terms of adjacent level fractures for this treatment of OF4 with this. Is it a greater or lesser problem compared to the lesser degree of fractures?
So first of all, sorry for the technical issues, but no, we did not find any increase in adjacent level fractures in this cohort of patients in OF4 type 4.
And Ricardo, if I may ask you, these types of fractures have a reputation for pseudoarthrosis, which is why they're called unstable. They tend to develop significant deformity. Is that your experience? Did you find any increasing amount of kyphosis? And did it matter in terms of the outcomes of these patients?
Yeah, so I do think kyphosis is correlated with a higher degree of pain in most of these patients. And actually this happens usually in the first 3 months. So we don't think that was a factor here that could impact our comparison with kyphosis and the conservative treatment. So we do see it somewhat in our patients, but I think here the augmentation had a nice impact in this type of patients.
So another question from Dimitri Van Popter. You, about 70% of your interventions, as far as I could see, were vertebroplasties. In what instances would you prefer kyphoplasty? Or to put it another way, why do you use vertebroplasty more often?
So that's a very good question, actually, because we did about 70% of vertebroplasties compared to 30% of kyphoplasties in our study. There are several reasons why we did that. First of all, as I've shown, the topography of the fracture itself, it's quite hard to insert a balloon in, and many times you end up breaking through the end plate. Since we've included a portion of the period during the lockdown, actually, since there's no studies comparing currently showing that vertebroplasty is superior to kyphoplasty or vice versa in terms of pain control, because of the lockdown and the initiative, the getting it right the first time. Since vertebroplasty is a much less expensive procedure, we opted to do mostly vertebroplasties in our patients.
And Ricardo, I'm not sure if you know the sort of NICE guidelines for vertebroplasty and vertebral augmentation. How would your results sit in terms of some perhaps updated NICE guidelines for this indication?
So if I understood correctly, you're asking whether the NICE guidelines should be changed or not, according to our paper. I think it's too early to do any recommendations, especially globally for our country. This is a small paper with a small number of patients, so I think the way forward now is to do a prospective study with a large number of patients, possibly multi-center, and then we can think about changing the guidelines or not according to the outcome.
Thank you, Ricardo. Darren Liu, are you on voice at all? Or are you still typing? Are you able to contribute, Darren? It doesn't seem that we have him on.
If we've got time for me to ask another question to Ricardo, if I may. So Ricardo, just one of the other limitations that the patients undergoing surgical intervention were much younger than those who were having conservative treatment. So the mean age of those having surgery was 74 and those with conservative care 78. Do you think actually the bias in terms of that tends to be a current practice, that people tend to not want to intervene in older patients, but surgeons are more willing to operate on younger patients? And just some of your thoughts?
Yes, for sure. That's a great question. So for sure there can be a bias because, as in any other specialty, we are more prone to operate in younger and fitter patients. But actually in our group of patients, this difference, albeit it was there, it wasn't significant. So if there was a bias, at least statistically, we found that it wasn't significant.
Thank you.
And we've got probably about a minute left. So to all our speakers, and even to our resident expert, Professor Sahota, question from Annabelle DeSalvo. When should we do a vertebroplasty, and when is a reasonable cutoff time when perhaps that intervention, we missed the best time for that intervention? So Ricardo, just in 10 seconds, give us your view.
So according to the vapor study, quite quickly, we found out that vertebroplasty can be successful in the first 3 weeks, but actually in our study we found that it can be actually more successful even at a later stage.
Yeah. Vicky, are you still there, Vicky? Because in Stoke you've been sort of kind of gently critiqued for waiting longer than 6 weeks. How's too long for you?
Sorry, can you repeat?
No, it's for Vicky, actually, if she's still there. No.
Oh, here she comes. Oh, no.
Upinder, in the last 9 seconds of this
yeah, so I think everybody knows my feeling is that clearly if you're unwell enough with severe pain to be admitted to hospital, the last thing we want to be doing is putting them back into another hospital bed. So really, if there's a surgical target and we can do it early, we should get on and do it early.
And on that, I think we should end because it's a fitting end. And so, on behalf of BritSpine, I'd like to thank our speakers for their wonderful contributions and for the audience for staying with it, and despite technology, some really great questions. So we'll conclude now and have a good remainder of the conference. On behalf of Pind and myself, thank you very much and goodbye.
Thank you.